Hello and welcome to the channel. This is Dr. Prashant Shukla and I have come up with a routine phacoemusification, and I'm going to demonstrate how to give a posterior subtenon anesthesia. The inferior nasal part of the conjunctiva is cut, bluntly dissected, and a 23 gauge curved cannula is taken and about 2 to 2.5 ml of lignocaine plus adrenaline is injected. The eye is now anesthetized and the surgery has been started. I am sitting temporarily. One side port has been made. Entry capsule is now being stained with trypan blue. After the dye wash, AC is filled with visco and a 2.8 millimeters main phaco incision is now being created, a triplanar incision. Rexis is started with a Subtenon. A flap is being raised and the flap is gradually moved in a circular motion. Few steps of the surgery are purposely slowed down for better understanding. AC is filled with some visco. Forceps is being taken now. This is a Dr. Haldipurkar's capsulorhexis forceps. Slowly the flap is moved and the rhexis is completed. Cortical cleaving hydrodissection is done. Fluid wave can be seen. The other side of the nucleus is tabbed and the mobility of the nucleus is confirmed. Some more fluid is injected and the other side is tabbed to release out all the fluid. The nucleus is free from its attachments now. The phaco needle is inserted. Phaco part in this surgery is almost unedited. And here I am going to do a stop and chop. The hardness of the nucleus is around NS3 plus, near NS4. The age of the patient is about 75 years and this is the left eye of the patient. The power being used here is 65. The bottle height is kept at around 100. The vacuum in sculpt mode is 85 and this is a venturi based system, so the aspiration flow rate is automatically controlled by the machine. First a small pit is being created and the central core of the nucleus is debulked, which is the toughest part and the hardest one. Sinski is then taken and the nucleus is now going to be split into two parts. In this case, the trenching was not very good, it was more superficial, and I should have done a bit more of deep trenching. So I did not get a very smooth cut break up to the posterior plate. Nonetheless, now is the time to switch on to the segment removal. The phaco power being used here is again 65. Vacuum is 250. The needle is embedded into the substance of the nucleus and a direct chop is done. The free nuclear piece is now being emulsified. The nucleus is then rotated. The phaco needle is embedded in the substance. Vacuum used here is around 250, and I've got a very clean chop. And again, this free nuclear piece is emulsified because I want to have some space in the bag, considering the hardness of the nucleus. The nucleus is pretty hard, and now again one more free nuclear fragment is being picked up, brought in the center at the level of iris plane, and slowly and surely the nucleus is now being emulsified. Many times small fragments get entangled in the side port, so it has also been manipulated and emulsified. Now I come out and time to replenish the OVD, because in these kind of cases we have to also protect the corneal endothelium. So here I am instilling HPMC to protect the cornea. Now half the nucleus has been taken care of, so now I am rotating this other half into proper orientation so that these pieces can also be emulsified. The surgery is minimally edited and the nuclear management is almost unedited. So the phaco needle goes in again, and one nuclear fragment is again held with the same vacuum 250. And it is being emulsified now. I prefer doing all the emulsification at the level of the iris plane and not exactly into the capsular bag. This is a slightly bigger piece and I am going to just chop it into a smaller one. The surgery is a low pressure, low flow surgery, and slowly the nuclear piece has been emulsified. I am not moving the phaco handpiece but trying to just feed the nuclear pieces with my left hand. The nuclear pieces slowly go into the phaco needle and the nucleus is being emulsified now. Now I am gradually stripping out all the cortex, and the vacuum here is being used is 350. The cortex is held, the anterior edge is held and gradually brought towards the center, and then it is emulsified. One can use a bimanual or even Simcoe cannula to do that. That is personal surgeon's preference. Now the time to implant the intraocular lens. This is a single piece hydrophobic aspheric monofocal foldable intraocular lens, and it's been loaded into the butterfly cartridge just like that. Some counter traction has been applied using the Sinski. One haptic goes directly into the capsular bag and slowly the whole lens unfolds in the eye. The other haptic is also just dialed into the capsular bag using the same Sinski hook. I normally use a small blunt Sinski for all my operations. I normally do not use a very sharp chopper, a long chopper, and this does the job very well. Now I am removing the viscoelastic from behind the intraocular lens. Now the visco has been removed from the anterior chamber. Some sticking over the anterior lens surface is been removed now. Now is the time to close, and here I am hydrating the roof of the incision. Also the sides for a proper watertight closure. This has been done using the same 27 gauge cannula. Some intracameral moxifloxacin has been instilled. That's it, the case is done. Hope you like the video. Please do share, like and subscribe my channel. Thank you so much.